All right, why don't we get started? Good morning and greetings and welcome to the International Healthcare System and COVID-19 Lesson Learned under the auspices of Kuwait Association of Surgeons, chapter of the American College of Surgeons. It's 9 a.m. in Washington, D.C., Eastern Standard Time, 3 p.m. Central European Time in Madrid, Spain, and 4 p.m. in Kuwait. I'm Wadah Rifai. I serve as the Regional Chief of Surgical Oncology at MedStar Georgetown. I also serve as the Surgeon-in-Chief Lombardi Comprehensive Cancer Center. It's my honor to serve as your moderator today. And first, I want to thank Kuwait Association of Surgeons for hosting this excellent and outstanding webinar. We have three great international surgical leaders from three health systems who will share with us today their insights and expertise during the COVID pandemic. We wish everyone is safe and healthy. Specifically, this is a very proud moment for me as an academic surgeon to introduce three surgeon leaders from three various systems. Our three speakers, first is Dr. Lisa Boyle. She's the Chief Medical Officer and the Vice President for MedStar Georgetown University Hospital. She's one of top 40 executive within MedStar Health, one of the largest academic healthcare system in the Mid-Atlantic area, and she's a phenomenal endocrine surgeon. Our second speaker is Dr. Salman Al-Sabah, who's the founding chair of surgery at Jabr Hospital in Kuwait. I saw firsthand how he transformed the hospital by growing the surgical service line. He's also a governor of the American College of Surgeons and the current president of the Kuwait Association of Surgeons. And last but not least, our friend and colleague, Dr. Julio Mayol, who's a professor of surgery in Madrid, the Chief Medical and Innovation Officer, and on the editorial board for British Journal of Surgery, the Journal of GI Surgery, and World Journal of Surgery. He's a major influencer in the social media world, and he's an outstanding GI surgeon. Thank you all for joining us today, and thank you for taking the time. I'll just go through some housekeeping items for the speakers, for the panelists and for the participant. Feel free to send your question through me. I'll field the questions and I'll share them with our panelists. The agenda of each of our speakers will be given 5 to 7 minutes to go over their strategy with the COVID crisis and pandemic. And then after that, we're going to open it up for specific questions around certain aspects of the COVID. And then we'll spend the last part of the webinar for questions from our participant. Thank you again. We'll start with you, Dr. Boyle. Thanks again for your time and thanks for joining us.
Okay, thank you, Wadah. Let me get my slides up here. Thank you. Great. Well, welcome everyone. And again, Dr. Al-Rifai, thank you so much for organizing this wonderful opportunity. I just want to give you just a very high-level overview of who we are at MedStar Health, because I do think how we manage and are managing through this pandemic is fundamentally part of who we are as an organization. As Dr. Al-Rifai said, we are the largest non-for-profit integrated healthcare system in the Mid-Atlantic region. We cover 3 states, Maryland, the District of Columbia, and Northern Virginia, 10 hospitals, over 300 sites of care. We employ a little over 30,000 associates, 1,200 residents and fellows, 1,100 employed physicians. In the pre-COVID era, we saw a little over 1 million ambulatory visits annually and about 134,000 inpatients. Our organizational structure, it's fairly typical. We have a corporate executive team led by our CEO, Ken Samet. I sit on the leadership team, which is the top 40 executives within the system, and then the 300 senior managers. And then this structure has been in place for about 20 years, and I think really has helped us manage through this pandemic, having a good, solid organizational leadership structure. We have a very strong organizational culture that's rooted in service. Our mission, vision, and spirit values guide us. As well as the implementation about 7 years ago of the safety science of high reliability that is foundational to our organization. It seems like it's hard to imagine a time before COVID, but this brief timeline shows us that just not quite 3 months ago, we admitted our first COVID patient, and here we are 3 months later with over 6 million cases worldwide and over 370,000 deaths. So continuing to manage through this pandemic. This is not at all unfamiliar to anyone on this webinar. There have been tremendous challenges. I think the number one challenge early on and continuing today is the uncertainty of this rapidly changing disease. Early on, we were hampered, as I think many jurisdictions were, by the lack of testing capabilities, which we have, for the most part, overcome. And then obviously the ever-changing algorithm for treatment of these folks. So at MedStar Health, the approach we took is on January 29th, when we saw what was happening worldwide, we set up an operational structure that we still have in place today. We have meetings on a daily basis, and it's organized along all of these different elements of performance, from clinical guidelines, supply chain, communication. And I want to focus, just as an example, on two really critical elements that I think have helped us manage through this pandemic. Obviously, as we all know, one of the big challenges of dealing with this highly infectious disease has been the ability to have appropriate supplies and equipment. So our system leadership took responsibility for international sourcing, contracting, and acquisition, and set up policies around the use of protective equipment. And then about 6 weeks ago, we embarked upon an ambitious and I think highly successful extended use and conservation strategy that's allowed us to be relatively in good place with respect to PPE. And then locally here, our leadership, our local supply chain leadership, working with clinical partners, are responsible for managing and implementing these policies. We are very data driven. This is just a quick example of a report I get on a regular basis that shows our usage, and this is since we've implemented our extended use project. The other element of performance that I think has been critical to our success has been in our capacity management. So early on, we had large multidisciplinary groups that worked on surge planning, particularly on our inpatient and critical care, but also in our frontline emergency department. We did stand up a second non-COVID emergency department. It was a great collaborative effort. Redeployed individuals from around the institution, including Dr. Al-Rafai and myself, and our colleagues from a number of different departments to staff this emergency department. The other really great collaboration was with our local jurisdiction, the government of the District of Columbia, to stand up an alternate care site at our convention center to care for low acuity COVID patients. Obviously, like everyone, the ability to manage the peak of our crisis required us to stand down from all non-urgent surgeries, and that occurred here at MedStar Georgetown on March 19th. And this allowed us to create capacity to manage our surge volume, allowed us to manage our resources and our personnel. And while we did continue to perform our non-elective procedures, I relied very heavily on our clinical leadership to assess the appropriateness of care. We're, as I said, very data-driven, and we really have an abundance of data that helps guide us along a lot of different avenues of our performance. This is just one slide of a slide I get daily that shows our COVID volume here, and you can see gradually over time we have had a resurgence of our non-COVID patients as they have migrated back to the inpatient arena. This is just a slide depicting, I get this every day as well, that depicts our total COVID volume. You can see rapid rise to our peak here in early May, and then we're on a slow sort of sawtooth decline. Still have quite a bit of a burden here in the hospital. Just a few outcomes data. We have cared for a little over 3,000 inpatients, 5,200 ambulatory patients. Our inpatient mortality is about 16%, with about almost a third of our patients requiring intensive care. and half of those in the intensive care have required mechanical ventilation. Our survival in those ventilated patients has been 50%, which I think you'd agree compares favorably to the currently published data. Human resources has been a great support. Our associates obviously have been stretched thin by this, but we've offered a variety of different supports for our folks. And then obviously communication has been critical. So we've used multiple different avenues to communicate, both in person and through different communication vehicles. We have a landing page that has all of our, in one stop shopping, all of our policies and procedures. And then we've had a tremendous outpouring of community support, lots of food, gifts, and really a tremendous amount of money that has been donated for funding all of our different research projects. We're now in the phase of beginning to resume, air quotes, normal operations, primarily looking at re-engaging in our elective surgery. And we are working very closely with our leadership here, clinical leadership, to do this in a very safe way with pre-op testing of all of our patients, associate screening, and a broad communication plan to assure that that it's safe to come back. So Wada, I will stop there, and thank you very much for the opportunity to give this presentation.
Many thanks, Dr. Boyle. I really appreciate you taking the time and giving us the overview. I'll move to our next speaker, Dr. Salman Al-Sabah, to give his perspective about the COVID pandemic in Kuwait. Dr. Al-Sabah, do you want to share your scheme, please?
Sure. Just thank you, first of all, Allah, for moderating the session, and it's really an honor to be part of this presentation. And I would like to also thank the speakers for the opportunity and for being and supporting this initiative. Just want to need to upload my presentation. Can you see my presentation?
Yes.
Yes, excellent. You're up. Thank you.
Okay, good. All right, so as Dr. Lisa mentioned earlier, we reached almost 6 million people with coronaviruses, and with a case fatality of 5.9%. And also, this is an important just published paper in The Lancet talking about 30-day mortality with doing surgery as a surgeon. It's 24%. So this is an important fact that we have to keep in mind when we consent our patients for surgery. So just to give you some general thoughts about what happened in Kuwait, we had extreme measures implemented early on since February, and then we escalated that measures from partial curfew to full curfew, and with multiple measures that you can see on this graph. And we had full lockdown in May 30, and 2 days ago, we just, May 31st, we reduced it from full lockdown to partial lockdown. Now, we have also the Ministry of Health present daily news about our data in terms of number of people affected with the coronavirus, mortal number of deaths, as well as number of tests, and also nationalities. And that to keep the public informed, as well as people interested in research as well, to be involved with that. Also, in terms of where we are in the graph, it's very difficult. Now we can see different models we have worldwide, and all these models have predictions, but we have multiple models in the Ministry of Health, and this is one of them. And basically, you can see that we seems that we are, we reached the peak, but with a small dip down, but we need to have more data to understand this graph very well. But at the end of the day, we know that the numbers are increasing, but now we can see it seems that we are in plateauing now. But we have to keep in mind always, this is a dynamic process, and a second wave could come. So we should be ready for this. Now there's multiple, brochures and recommendation from the Ministry of Health that we follow. This is one of them: how we deal with patients coming to the emergency room with COVID or suspected COVID patients. Also, the COVID era helped us to boost our technology part. So this was, one of the good things about COVID is to help us to push more technology. This is an app that we use in the Ministry of Health to quarantine individuals and also to trace them. Now, in order to have a successful outcome in any country in the world, we have to think about, if you summarize this graph into 3 elements: you need the government, you need the private sector, and you need the community or the non-profit sector, or we call it the plural sector. If you have three of them working together, you're going to have a better outcome, because it needs the whole nation has to work together in a balanced way, so that we can have a better outcome. I would like to focus also on non-profit organization here in Kuwait. They did really great job, supporting grants, food, and even hotels for free to the Ministry of Health. That helped a lot with this challenge. In terms of how we ranked and in terms of how we did, this is one of the publications. Seems that Kuwait, you can see from this graph, had one of the highest in this part of the world in terms of preparing for this kind of event. Now, role of surgeons, surgeons did a great job here in Kuwait. Some of them are involved with leadership positions, some of them are involved in operating in emergency cases, field hospital, organizing, quarantine sites, education, research, manufacturing even. So there was a big role for surgeons outside the OR in this era, which is really something we have to think about and reflect on. In terms of society as CAS, this is what usually we focus on, is education, information, and doing some webinars like what we're doing right now, as well as public awareness and push innovation, as well as networking. So what we did so far is that we did multiple webinars on how to be safe and how we take care of ourselves in terms of PPEs. Also, we train surgeons with ventilator courses and crash courses in airway, as well as on COVID. And we have also, the resident did a great job in terms of doing online meetings, and we can keep the education ongoing. As well as, we came up with recommendations. This is one of the recommendations, work together with Women Surgeon Committee, Kuwait Chapter, and CAS. We came up with this document, which we gave it to the Ministry of Health, so they can, learn from this recommendation and use it. So what we learned from hospitals, first of all, we need to know where we are. So in Kuwait, we are, in terms of, if you look at physicians in 1,000 people, if you compare, for example, Kuwait, which is like 2.4 for every 1,000, and let's say in the US is as you can see from the graph, where is it here? Okay, so it's 2.6. So you can see, you have to understand how much you can give as a service. So we need to know where we are, not only for physicians, but also for nurses and so forth. So we need to know where we are to understand how we can manage this problem. I come from this hospital called Jabir Hospital. It's one of the biggest hospitals in the region. When we started, as Dr. Waddah mentioned earlier, we were using only 15% capacity. But during the COVID era, within few weeks, we went to full capacity. So we went to 1,000 plus beds. And at this stage, we have 148 ICU beds and 110 occupied right now. But also we have a potential to increase that, which we are doing right now, to 240. I think the surgeon in this hospital, they've been involved in the lab, they're involved in the ICU, in the ECMO, and the different departments to enhance these departments, plus the on-call team as well. The other thing I noticed very important, if you can see from this is a publication, recent publication. If you can see, one of the important things, the most effective measures, going from most effective, least effective, is, if you can see here, you can see the engineers. Engineering control is very important. How we manage. In Jabir, we made sure that the pathways are clear, so we done less harm on our physicians. And I'm sure the other hospitals as well, whether in Kuwait or worldwide, looked at that, because PPE is least effective if you compare it to the other elements. So that's very important to know. Different hospitals in Kuwait did different things, focusing on telehealth. That was increased in this part of the world. We deliver medication to patients to their home, as well as nutrition staff. So each hospital did, increase their magnitude in terms of telehealth and virtual capacity as well. Also, training has been done. You can see here doing virtual training on intubation and so on. Private sector, you can see also very involved. This is one of the hospitals in the private sector, Salam Hospital, where they focused on remote telecom, where they can manage their patient for free, which is, and even other hospitals in the private is a similar work. So there is more boost into the technology and using of telehealth. This is another important thing that we focused on is manufacturing. So we looked at, because of the deficiency in worldwide about PCR testing and so on, we focus on how we can build in-house PCR kits, and that started with 3D printing, you can see here, and went up to the PCR itself for extraction. Also, we utilized augmented reality telesurgery by doing, as we know, we really limited our number of health workers in the operating room, especially for surgeons. So we in COVID case, we said 2 specialists goes and operate. But in this case, we had to have 1 specialist inside and the rest were outside. You can see that hand was by virtual reality. We can, do this, help him and give advice from outside the operating room, whether you're in the hospital or somewhere else. Multiple webinars have been done. This is with Mount Sinai, New York, and with Taiwan. Taiwan has really great experience and successful experience with 40 days without any COVID cases. So we learned from them. We also had in the Gulf region, we had a meeting with the surgeons and we discussed how things have been done there. We also focused on digital health. And what would help us with the digital health is that our ex-US ambassador here from Kuwait, you can see his picture here, Mr. Silverman helped a lot with that. And this helped us to have our great network to do such events and understand more about digital health. So in return to new normal, I think there is multiple phases done by Ministry of Health. And we started May 31st to reopen after full lockdown. And there's a lot of, we looked at different options and things. But the most important thing that I'd like to focus on here, it's a dynamic scenario. So do, plan, act, and study. So we go from one stage to another and we study every time because it's a dynamic scenario. It's not just a fixed or static scenario. And this is, do, plan, act, study is actually a concept from Harvard. And the whole idea is that we have to, plan, do, and then study what we have done, and then we act again, and so on. And we have different stages of that. First stage, second stage. It depends on each country, capacity. In Kuwait, we have this kind of work been done so far. And in terms of return to scheduled surgery, we plan to go back, early with October. But we started with clinics, 30% at this stage in each hospital, and then we're going to increase and see how our numbers do and how our ICU capacity and our blood bank, how they are doing before we move even further. Elective surgery was postponed since March, and as many other countries. We only do emergency cases and cancer cases, but we're gonna now again study this and hopefully by, we planned as, early as October to start elective surgery, but this is ongoing reassessment. Now, there's other innovations that happen in this part of the world, was looking at how we're going to go back to normal using and protect ourselves. So there's this kind of artificial intelligence plus real-time management of people in Kuwait is on the process. And to summarize all that, what I learned. So as being in different positions, I think that it's a concept developed by Harvard, really fits in this COVID challenge, which is meta leadership. So you have to aware about yourself, you have to take care of yourself, but also understand yourself, but also understand the situation. The situation now is not just healthcare, it's healthcare, politics, media, legal. We have changed our law for this challenge, for this pandemic. And we have to think about economy and environment. So it's much more complicated than what you think, but you need to understand as a surgeon what's the situation you are in, and also what's your network. And behavior changes as another factor. In addition, that risk factor, we talk about COVID, which is like surgery is by itself, as I said in the beginning, it's a risk factor, but also obesity, diabetes, and this kind of thrombosis we are seeing with COVID, also it needs a lot of understanding. So I think with collaboration and by doing this kind of meeting, sharing our knowledge, I think we'll have a better understanding of this problem. Thank you very much.
Thank you very much, Dr. Salman, for sharing your insight. Very, very interesting perspective. Dr. Mayol, you're up. Please share with us your insights from Madrid, Spain, and all what you've learned since the beginning of the COVID crisis. I think you're on mute. Let me unmute.
Oh, sorry, I was muted and I didn't know. So first of all, thank you very much to the Kuwait Association of Surgery, to the organizers, for giving me the opportunity to share questions, more than answers, questions about what we have been going through and what have we learned about this, because this is of critical importance to all of us. To give you some context, the Madrid region is 6.5 million people in population, slightly larger than Kuwait. We have an universal coverage health system, pretty much like an NHS, which includes public health, primary care, and hospitals. Its budget is about $10 billion per year, funded by direct taxation by the national government. In Madrid, there are 34 public hospitals and 52 private hospitals and 423 primary care centers. There are private and public nursing homes, but they are not run by the healthcare system. And this is important because we have been hit hard by coronavirus, and especially at nursing homes, which explains why probably Madrid has the worst record in terms of deaths by 100,000 inhabitants. In Madrid, we have a national and a regional center for disease control under two different administrations, which makes it difficult to coordinate. And on March the 13th, the country declared the state of alarm. And all the health-related decisions were centralized. However, the regional government retained the management of healthcare delivery. So basically, we had to coordinate primary care, first of all, public health measures, primary care, the hospital network, and nursing homes. In my hospital, we are a 700-bed university hospital with over 800 physicians and around 400 residents. The total number of employees is around 5,000. And basically, we have done exactly what Dr. Boyle and Dr. Osaba explained. In addition to that, we also have the convention center transformed into a hospital for less complex cases. Let's put it that way. Several hotels in Madrid were medicalized to be used by patients who couldn't go home after being discharged from hospitals. And some hotels were adapted to accommodate healthcare professionals who couldn't or didn't want to go home because they were afraid of taking the virus with them back home. So we hire, at my institution, we hire additional personnel, over 400 people. The number of beds were ramped from 700 to 1,200. The ICU beds went from 36 to 93, and the building was adapted to have two designated areas for COVID-19 positive patients, for the emergency room, general wards, imaging, ORs, and ICUs, and for COVID-19 negative patients. So we were able to do emergency cases for surgery, basically, and also for the stroke code, MI code, and all the rest of the codes that we have to provide services for the rest of the region. And then also the COVID-19 positive area, we, at the top of the infection, we had around 900 patients, COVID-19 positive patients. And around 60 in the ICU. Our mortality rates basically the same as described by Dr. Boyle. And what we have seen here, we failed. We must admit that. We as a society failed. This is the whole thing about flattening the curve was to avoid collapsing the healthcare system. And it didn't work. We were too late. We implemented measures too late, although there was some experience from 2009 with H1N1 pandemic. We were late. People didn't make the right decisions. They have data. They were warned, but for some reason, we were late making decisions. Cognitive bias, call it what you want, but there was something wrong with our mindset. Then we worked very hard. This is not a healthcare crisis. This is not a crisis of the healthcare system. This is a crisis of society, particularly for Western countries, and for those in the Middle East, for some of them also, because we were making the wrong decisions, or we were making them too late. And that's my experience being chief medical officer. We worked very hard. We had teams. We replaced people as they got infected. But remember, there was a shortage of PPE everywhere. The United States and Europe had outsourced the key asset production to the rival, to the economic and ideological rival. That's amazing, something unbelievable. In addition to that, we didn't have enough PCR testing. We were late implementing it. What else? Around 20% of our personnel were at some time in the timeline. They were on sick leaves because they had been exposed, or they had mild symptoms, or a positive PCR test. So we couldn't replace critical personnel in the ICUs, not because we didn't have the ventilators or the beds, the physical beds. It's because we didn't have trained personnel to take care of the patients. So we did something wrong. We didn't pay enough attention to protect healthcare workers. We did not pay enough attention, or we made the wrong decisions to implement strict confinement early in the pandemic. And in addition to that, ventilators and tests were delivered late to our healthcare system in order to do what we now can do, but now the virus is almost gone. We have right now today, as of today, we have 7 COVID-19 positive patients in the general wards and 2 in the ICU. That's about it. No more patients in our emergency department. So basically, we have worked very hard. Healthcare workers have given the best of the best, putting their own lives and the lives of their relatives at risk. But as a society, we have failed. And this is what I think about what has happened here in Madrid.
Julio, can you hear me?
Yes.
Yep.
Okay. All right, we lost you for a second.
Okay. Am I back?
You're back. Yes.
Yeah. This is what I have learned after over 3 months with this pandemic. It was that we haven't failed as a healthcare system. We have failed as a society. And we were just at the end of the chain of the value chain, and we suffered more. And our teams worked very hard. They put their own lives and the lives of their relatives at risk. We have given, and my colleagues have given the best of what they have. But the problem is that we have failed. Can you hear me?
Yes, thank you. Thank you very much, Julio, for your presentation. Thanks a lot. I appreciate it. We'll move on to the second part of the web with a exciting webinar that we have at the moment. Our speak as a surgeon, as a
So, again, it's always nice to see you and hear from you. And we've been a long time since we see you in Kuwait. And I'm happy that now the situation is better in Madrid and things are getting better.
Much better.
That's good. And,
I was just looking at the questions. Up there, he's back.
Yeah.
Wada?
Yes, I'm back. Sorry, I lost.
Oh, there you are.
Yeah. So I don't know if you heard my question or not. At time of crisis, uncertainty becomes the norm. My question to you, and then I'll pose the question to others. Speaker, how did you handle that? What was your strategy with uncertainty?
Wada, we missed the beginning part of the question.
The question is, how did you handle uncertainty during the COVID crisis?
So, yeah, that obviously a great question. I think in my 35-year career in surgery, this is obviously unprecedented. And I would say one of the key features that I think was successful for us was our communication strategy, because we have obviously a diverse workforce, and being able to communicate very clearly our strategy in addressing concerns, listening carefully to our associates and our providers, what their concerns and their worries. The ability for us, I think, to get out in front of some of the challenges, particularly, and Julio mentioned PPE. We very, very early on, very aggressively managed our PPE supplies so that our associates felt safe caring for these patients. So I think, strong leadership, good, frequent, clear communication, encouraging people to feel as though that, we've got this situation under control, acknowledging the uncertainty, embracing the uncertainty, dealing with day-to-day what we know, what we don't know. And, we're still here, despite a softening of our numbers. We still have over about 350 COVID patients, inpatients that we're dealing with. So we're still very much in the middle of this. But I think, communicating clearly, giving people data, giving people numbers, giving people facts, because I find that in the absence of all of that, nature abhors a vacuum. And so in comes opinion and anecdote. So those are just a couple of thoughts, but would love to hear from my fellow panelists on how they managed uncertainty.
Thank you, Lisa. Julio?
Yes, very good points. For us, first, leadership is critical. In addition to that, being transparent helps. And we created this emergency committee that included people from communication, continuity of care, ethics, human resources, key assets and critical infrastructures, infection prevention and control, case management, with people from the emergency department, infectious diseases, internal medicine, and intensive care. In addition to that, teamwork, building multidisciplinary teams, it helps a lot because they provide different perspectives to solve very complex problems. When there's a lot of uncertainty, making decisions may be easier if you have knowledge, if you have a multidisciplinary team making decisions. So as a leader, you have to acknowledge that there are a lot of people down there in the game, making the right decisions. You must support them. So teamwork is essential. In addition to that, communication. All we do is about communication in medicine, everything. Healing starts with communications. That's what I usually repeat. Followed up, modifying a quote by Jeff Matthews, my mentor. Healing starts with communication. There's no way to heal a person or a system if we don't communicate, because that's what human beings does for a living. And next, speed to adapt to changes. You have, in a pandemic, Michael Gray, the director of the World Health Organization, repeated this, the executive director of the WHO, repeated this frequently. In a pandemic, the speed trumps perfection.